Hi, my name is Matt Goldblatt, and today I'm going to be talking about absorbable synthetic mesh. These are my disclosures. The most important set of disclosures I want to discuss are that there are no FDA-approved products for the use in hernia repair that have the indication for any level of contamination. So any permanent mesh, absorbable mesh, and biologic mesh are only indicated in CDC Class 1 or clean wounds. Therefore, all discussions today of the use of any of these materials in cases with any degree of contamination will be considered off-label. So some objectives to a quality ventral hernia repair. The most important is to prevent hernia contents from protruding through the hernia orifice. And we also need to reestablish GI continuity or maintain GI continuity. We need to provide a durable hernia repair with a low recurrence rate. I want to perform the procedure safely with minimal patient morbidity. Need to reduce the post-operative wound complications and long-term mesh infections. And I'm going to reconstruct a functional dynamic abdominal wall to the best of my ability. This comes in many different shapes and sizes. Certainly a small umbilical hernia like this would be considered an outpatient procedure, probably wouldn't even use any mesh and would just use suture. Versus this patient who has an intercutaneous fistula or two, multiple problems with wound healing, is on steroids, has had multiple skin grafts, etc. So this case, the goals in this case are vastly different than the goals in this case. In order to reinforce a hernia repair, we typically will use some sort of material, which we're going to call mesh. And some of the ideal properties of this material I've listed here, and these are in my opinion. I'd like it to be strong with immediate and durable strength to allow healing and tissue ingrowth. I'd like it to be resistant to infection, if at all possible. Again, off-label, but it'd be great if some of these materials wouldn't get or maintain a chronic infection if there was contamination. If they're going to be placed in the abdomen, I'd like it to have an adhesion barrier or at least have properties that minimize adhesions. And certainly adhesions are bad and fistula are worse, and so we wouldn't want any fistula formation. It'd be nice if it was easy to use, come in multiple sizes, packaged on the shelf that you can just open and use. It'd be nice also if there was no systemic inflammatory response. A local tissue response is useful to help stimulate healing, but an inflammatory response systemically is a problem. And it would be also nice if they were cost effective. A lot of these newer materials can be quite expensive, and so we have to keep our eyes on cost containment. So what are some of the concerns with biologic meshes? They were the first really material for complex hernia repair on the market, and they have been very expensive. They've raised the eyebrows of people at the FDA and across the hernia realm at the cost of some of these materials. They all require some sort of back table prep, although that has been streamlined quite a bit. We don't have to defrost and rehydrate these as much anymore, but still some sort of back table prep is needed. They are derived from animal or human tissue, and so the concern of patients, whether or not it's from a cadaver or from certain animals, sometimes brings up religious concerns, and so that's one of the problems. They used to be limited in their available sizes. I think most of these now have developed or come in much larger sizes, and so that's not as much of an issue. But the important thing to know about collagen is that collagen is all cross-linked, coming from either humans or animals. The level of cross-linking changes from species to species, and some of these are cross-linked post-mortem in a lab. And so that has some degree of concern related to tissue ingrowth, and that also leads to encapsulation and seroma formation. So that's one of the concerns. I'm going to go now to the absorbable synthetic materials. The first one I want to talk about is Tiger Matrix. It is a polymer of two separate materials. It is a fast resorbing fiber and a slow resorbing fiber, shown here. The fast resorbing fiber loses mechanical strength in a couple of weeks, so it's pretty quick. It does fully reabsorb in 4 months. And the slow resorbing fiber maintains a significant portion of its strength for up to 6 months and completely reabsorbs in 3 years. There's some limited data on Tiger Matrix in the literature. Here's a study looking at breast reconstruction, basically an abdominal wall reconstruction. Limited results of this, more some anecdotal stuff. Here is where they implanted the material in sheep. It's relatively small defects, and showed that it, when they harvested the material after a couple of years, there is collagen growth around it, as well as an inflammatory response associated with it to some degree. It's also been looked at in inguinal hernia repair, and they followed these Lichtenstein type repairs for 3 years. If you think about an inguinal hernia repair, a lateral repair is an indirect hernia repair. They had no recurrences, but in the medial or direct hernia repair, it's basically a bridging ventral hernia. And in that situation, they found a 44% recurrence rate, which is not surprising when you use an absorbable material in a bridge. The next product I'd like to talk to you about is Phasix. It's a knitted monofilament mesh that's made up of poly-4-hydroxybutyrate, which is a material that is derived and harvested from E. coli bacteria. It is then polymerized and made into a mesh. It is fully resorbable in 18 months. And on some of their preliminary studies, they show here at 6 weeks that the material is white, and it shows that there is some macrophage and other inflammatory cells around the material. And then at 2 years, the inflammatory process starts to wane a little bit. The material is still present, and there's much more of the collagen formation around it. We've looked at this in human subjects. This is a study that I was a part of with the PI, Scott Roth, who we looked at the most complex hernia patients, those that have significant wound morbidity risk, including diabetics, smokers, obese patients. And these were all clean wounds, however. And so this was the first report of ours, poster at SAGES about 5 years ago. And in this early result of 50 patients at a year, we showed that there was a low recurrence rate of 2%. As we continue to look at all of our patients over increasing time points, you can see here that at 18 months, our recurrence rate was 9%. And as we continue to go out, we've got 3-year data coming out shortly at this SAGES with a slightly increase in all of the data so far, or all of the recurrence numbers. So as you continue to follow these patients out, and as the material completely goes away, the recurrence rates do seem to creep up. A study here looking at Phasix in a contaminated field, or at least some of the patients had contaminated fields. This is by Yuri Nowitzki when he was at Case, and it shows that in 25 patients, nearly 1/3 of these patients had either contaminated or clean contaminated wounds. About 18-month follow-up, there was 1 recurrence at 12 months, and that was an onlay, which is probably not the best place to put a piece of mesh. And 2 patients did have infection, but they were able to salvage the mesh in all of those patients. And the third polymer, or third material I want to talk about is BioA. BioA is a similar polymer as Maxon suture, if you're familiar with that. It has a number of highly interconnected pores. It degrades primarily by hydrolysis, and it is completely reabsorbed in 6 months. Here's some of their data looking at 3 days. There's some cellular infiltration between the material, and then as time goes on in a rabbit, at 7 days, you're already starting to see collagen formation, and at 14 days, you're seeing dense collagen formation. So because of the smaller nature of these fibers, there's allegedly faster tissue ingrowth. And there's some data I'd like to show you to back that up to some degree. This is the COBRA trial, which I was privileged to be a part of, as well as a number of highly regarded hernia surgeons around the world. And in this study, there are 104 patients. These are, again, off-label use, all class 2 or class 3 wounds. Our goal was to get these patients or the material in a retrorectus position, and we were able to achieve that in 90% of these repairs. We were able to achieve primary fascial closure in all of these repairs, which is important in an absorbable material. The recurrence rate we had was 17% using a Kaplan-Meier model. And if you split out those that were retrorectus, compared them to the intraperitoneal, we had a 12.7% retrorectus recurrence rate. I then looked at my own patients at our institution, comparing them between the retrorectus and the intraperitoneal. And when you look at just the retrorectus patients, we had an 8.1% recurrence rate at 22 months. And the majority of our patients were in clean wounds. However, when you looked at the class 2 and 3 and 4 wounds, the recurrence rate was 8.1 as well. So basically similar recurrences across the board, regardless of the level of contamination. So in conclusion, there are multiple polymers available for absorbable synthetic meshes on the market today. Long-term clinical data is limited in some, but as time goes on, we are gaining more and more data. There is certainly limited testing in contaminated fields, and partly because this is off-label use. There is no head-to-head comparison of these products. But the most common factor is that we must get fascia-to-fascia approximation. That was shown in both biologics and absorbable synthetics. And so if you're unable to obtain fascial closure, my recommendation would be not to use certainly an absorbable synthetic in that situation. Thank you very much for SAGES to allow me to present today, and I appreciate your time.